Welcome to StantonMD. I'm board-certified emergency physician Dr. Ryan Stanton. This month it's all about screening and prevention, in particular, cancer screening and prevention. Cancer is one of the most common killers of adults in the United States. In this episode, we will dive into some of the best screening tools and prevention available. We start with Dr. Tom Knopp talking colorectal cancer. Then Dr. Brennan Royalty will join us for prostate cancer screening. And then Sarah Smith with skin cancer screening, and wrap it up with Kentucky One's Yes Ma'am program. We start today with Dr. Tom Knopp, a gastroenterologist with Colorectal Surgery and Gastroenterology Associates. Colorectal cancer will impact 1 in 16 Americans, and he is fighting against this common cancer through screening, education, and treatment. The next question is to establish your risk and then take the steps to get screened. One of the biggest determinants of risk is your family history.
Well, colon cancer is the second leading cause of cancer-related death in the United States for men and women. So it's extremely common, and it's important to get screened because the first symptom of colon cancer is no symptom at all. A lot of times once the symptoms occur, the colon cancer is actually more advanced. So it's kind of why screening becomes a really big, important part of the picture. Now, if you look at the incidence of colon cancer over time, and if you look at it, say, on a graphic, the incidence stays about 0.1% all the way until you get about 40, and then at 40 it starts to slightly climb, and then at 50 we see a kind of a big peak. So that's why 50 is the year of age that we recommend screening begin for average risk individuals. Now, there are certain select individuals that need to be screened earlier, and that's important to discuss your family history and other things with your primary care physician or your gastroenterologist, and they can determine when screening should start for you. But the average risk person starts at 50 years of age. If you have any questions as far as your family history, discuss that with your primary care doctor. Your primary care doctor is usually going to make recommendations of where to go, as far as if it's our place here at CSGA or another gastroenterologist or colorectal person in town. They'll get you set up with that. A lot of people that come in open access. Actually, they're talking to the primary care doctor. This might be the first time that we meet them is right here in this room before their procedure. Other people, they come and visit us in the office for other reasons, and we might identify a risk factor that brings them in that would qualify them for screening.
The screening test of choice is called a colonoscopy. This is a procedure in which a camera is advanced through the colon to inspect for any lesions, masses, polyps, or other areas of concern. This test is the gold standard, and though many people fear the test itself, most report the worst part is actually the preparation.
We got to get you cleaned out so we can see. The scope that we use, the camera on the end of the scope is quite small, so you can kind of see in the channel that we use to remove materials is very small. So in trying to get a thick liquid or a solid through that, you can see why we can't get much done. So it's really important, if you're going to take the risk of the procedure, which is small, but there is some risk, it is a procedure. If you're going to take those risks, you want to give us the best opportunity to really screen your colon appropriately and see every inch that's available to be screened.
But once you get to the office, the procedure typically moves very quickly.
Procedure, once we get you nice and sleepy, takes about 15 to 20 minutes to do, and then we have you on your way out for lunch with your family.
A patient allowed us to observe and film his colonoscopy in order to help educate and promote prevention. Dr. Knopp walked us through the colonoscopy. After advancing the full length of the colon, he was able to identify a familiar structure as well as a polyp.
This polyp's probably only about 4 or 5 millimeters in size. It's not very big. It's the reason we do the exams, is to get these kind of things off of here before they become cancers. The traditional polyp, or what we call an adenoma or polyp, the cancer sequence, carcinoma sequence, it's theorized to take about 10 years. So something like this polyp here, probably take about 10 years before this polyp became a cancer. But on people with routine screening, we're doing them every 10 years. So, and that's really one of the theories on that. If you do have polyps, it does increase your risk a little bit to have polyps on further examination. So what we do is we bring people back a little bit earlier. So if you were to have a few polyps on your initial colonoscopy, your endoscopist might advise you to come back in 3 to 5 years based upon the pathology results. That if you have any one polyp greater than 10 millimeters, which is it's a centimeter in size. So any one polyp greater than 1 centimeter in size, or 3 or more smaller polyps, we bring people back in 3 years for their follow-up examination.
And just as quickly, it's time to get rid of that polyp with a device called a snare.
And we trap the polyp with the snare. Try and close down on that. And what you'll see is the snare gather the tissue underneath the polyp, and then we'll go ahead and make sure we got a hold of it nice and tight, and it goes right through. And that's basically your traditional polypectomy. It's this really small polyp. Yeah, you can put the trap on now. And we have a trap, we suck it up through the scope here, and then it'll be sent off to the pathologist for evaluation.
Fortunately for our patient, that was the only polyp found. This not only decreases the risk of cancer, but also can help the patient rest at ease that he is most likely in the clear until his next screening.
That polyp there is very small and not worth getting stressed out over. It's one of the things that by screening, you can alleviate yourself of that stress and not knowing what's going on. That polyp again 10 years from now could have been cancer, but you don't have to worry about that anymore.
As he completed the colonoscopy, Dr. Knopp stressed some of the keys to a quality exam and what to look for in the physician performing your procedure.
When you're going to get your endoscopic procedure done, that you're going to get a high quality examination. So, the endoscopists today, they should be keeping track of their withdrawal times, their polyp detection rates, their complication rates. All these things are important to make sure you're getting the highest of quality exams. So it's important for our community, and it's important for you as a patient to having this procedure done by somebody that's really has documented and can prove that they're providing a real high quality of service.
Colon cancer impacts men and women, representing one of the most common causes of cancer and cancer-related death. Getting your screening performed will significantly decrease that risk and potentially save your life. More StantonMD coming up. Stay with us.
Do you own or work for a business that advances health and safety of the public or its employees? Then you may be interested in becoming a sponsor of StantonMD. There are various opportunities for sponsorship, from the show to the website, social media, print, or a combination. For more information on becoming part of StantonMD, contact Jen at info@StantonMD.com. That's info@StantonMD.com. Now, back to the show.
Welcome back. One of the most common cancers a man will experience is prostate cancer. Statistics show that the vast majority of men will have some cancer cells or growth in their prostate as they get into their 70s and 80s. The good news is that most will never be of significance or require any treatment. The key is determining screening and plan, often involving a good primary care physician, evaluation, and education. Dr. Brennan Royalty is a family physician who helps us understand the prostate and the risk of cancer.
The prostate gland is in the male, and it is a reproductive organ. It's part of the urinary tract. It generally isn't an issue as far as any malignancies, such as prostate cancer, early in life, but as men age, it becomes much more prominent.
In actuality, we were doing more harm than good. This is because most prostate cancer does not require treatment.
So screening is designed to prevent cancer you're trying to catch it early. As they've gone through, they've realized that prostate cancer is, first of all, it's very prevalent. And is it treatable? Yes, it is treatable. Does it get to the point where it needs to be treated in most men? No, it doesn't. So, as I said, most men will develop some atypical cells that could look like prostate cancer. The treatment of prostate cancer also has its complications. So we've gone from everyone gets screened at age 40, digital rectal exams, age 50, and PSA at age 50 perhaps.
Unlike the majority of cancer that tends to grow quickly, prostate cancer is not like the others. In most cases, it grows slowly, if at all. There are some cases that are more aggressive, and those are the ones we need to catch and treat as early as possible.
For most people, if we detect a prostate cancer, we're going to watch it and see if it has any significant effects on voiding, urinary tract function, and make sure that it doesn't enlarge significantly and become much more of a problem faster.
From a patient standpoint, it is important to recognize the signs your body is providing and the symptoms that may represent a problem. The challenge is differentiating between the most common issue of the prostate and cancer.
Benign means it's not malignant. So we have what's called benign prostatic hypertrophy, which just means that the prostate is enlarged, and that occurs in men as we get older. It can cause symptoms of what's similar to an obstruction in the urethral tract. Trouble starting your urinary stream is one of those. Feeling like you have to go frequently, but then you don't is another one. Starting and stopping of your stream is an issue with that as well. Most of the time, for most men, that comes across as a very slow process that they begin to see as they get into their 40s, 50s, 60s. With prostate cancer, the symptoms are very similar. I think in general, what the patient needs to know is that if they notice an abrupt change in the way their urinary tract functions, that's very significant, because if something is changing rather quickly, then you want to be seen by a physician, because they may be able to find something early on, as opposed to as I said, the slow symptoms that come on with benign processes.
If you have symptoms, it's very important to have the right team.
Men are going to go to their family physician or their internist, and that's perfectly appropriate. As if a test is done which shows prostate, the potential for prostate issues, then they'll go to a urologist.
But the most important plan for you is to have a primary care physician and make sure you are seeing them regularly, because they will help you navigate life's changes.
With the changes in the screening recommendations between the different organizations, it's an education process between the physician and the patient to decide what they want to do. There's some folks that will say that, yeah, I want to find it as soon as possible, and that's okay to do. They just have to understand the risks associated with a prostate-specific antigen test, for instance. And others are just simply fine with waiting until they have actual symptoms. So it's a shared decision-making model where we try to explain to the patient the advantages of getting the screening and the disadvantages of getting the screening.
Many men will have some issues with their prostate during their lives, and most will have some form of cancer within the prostate at some point throughout their years. Whether they know it or not, fortunately, a close relationship with your family physician and good education will keep you on the right path. More Stanton MD coming up. Stay with us.
As a board-certified emergency physician, Dr. Stanton is a proud member of the American College of Emergency Physicians, also known as ACEP. ACEP provides physician and evidence-based patient resources at its consumer website, emergencycare4u.org. That site has stories, fact sheets, and advice on a wide range of emergency topics. From visiting the ER to mom tips, you can find them on emergencycare4u.org. Now, back to the show.
Welcome back. Skin cancer is the most common form of cancer in the United States. It's a form of cancer that impacts all ages, sexes, and races. Dr. Sarah Smith is a dermatologist with StantonMD who deals with skin cancer and other changes on a daily basis. Skin cancer is incredibly common, and like most cancer, the earlier it is recognized and addressed, the more likely you are to have a full recovery.
When a dermatologist finds a melanoma incidentally, or another doctor finds a melanoma incidentally on exam, it's more likely that that melanoma will be thin and easily treatable than if we wait until the patient notices a problem and then goes in. Those melanomas tend to be thicker. There are groups that definitely do need to be screened regularly, so that includes people who have had a melanoma, people who have a first-degree relative, so that's parents, siblings, and children, first-degree relative with a melanoma, people who have had other types of skin cancer, because if they've had enough to get one kind of skin cancer, they've definitely had enough sun to get another skin cancer like a melanoma. And then redheads And it's not just because redheads are more likely to burn, that's part of it, but really redheads have a genetic mutation to have that pretty red hair that puts them at much higher risk of actually developing a melanoma because their DNA cannot be repaired from ultraviolet radiation as well as someone else's can. And then people with a lot of moles. So if you have somebody that has over 100 moles, that person's going to be at higher risk too. So those are all people that I would say it's very important that they come in at least yearly and get checked. The older you get, the more likely you are to have skin cancer because you've been here longer and you've gotten more sun exposure. People think it's really just sun exposure in childhood that's the problem. That's a common misconception, but really what you do in your 60s still matters. So wearing sunscreen as a child is very important, but wearing sunscreen as an adult matters too.
When a patient comes into Dr. Smith's office, she has some criteria she uses to help identify problem skin lesions.
What I'm looking for, we talk about the A, B, C, D, E's. So asymmetry, irregular border, uneven color, diameter larger than a pencil eraser, and then the E is really the most important one, I think, and that's evolution, a mole that's changing, and that would be something that you would tell me on history.
She also looks in key body hotspots based on sex and race.
In men, the most common site among Caucasian men is going to be the back, which is hard for you to actually look at, but it's a great place where a spouse or someone you live with can actually check your back and look at your moles. For women, the leg is actually very common. Now, some sites people don't think about, part of where I come in is checking places like your scalp. You can't see your scalp. So I actually, when I do a skin check, I look through all of your hair to make sure that there's not a melanoma on the scalp, because although sun exposure is the leading risk factor for developing melanoma other than genetics, you can get them in places that are not sun exposed, and I think that's really a surprise to people when they come in, that it's not just the places where you've had sunburns that we need to look. It's really everywhere. And for non-Caucasians, so for African Americans, people of Hispanic descent, and then also Asians, we have to worry more about atypical sites like the soles of the feet and the palms of the hands and also the genitals. So that is a very uncommon site for melanoma generally, because most melanomas occur in light-skinned people, but in pigmented people, that's going to actually be more common than for you to have a mole on your back. That would be actually a melanoma.
The key is a thorough exam that scans every common and less common site a cancer may hide.
So I usually start all my skin checks once I've taken a history to find out if there are any moles or spots that the person's concerned with. I start at the top and work my way down. So I always check someone's head, and I usually encourage my patients who've had a melanoma, not just for me to check it, but every time they go to have their hair cut, for their hairstylist to check their scalp too, because I only see them either every 6 months or once a year, and the hairstylist will probably see them once a month or every couple of months, and so it can really help pick up on something if it would be there earlier rather than later.
Ideally, you don't want to have a dermatologist on speed dial. This is accomplished through prevention. There are many things you can do to prevent skin cancer, and several mistakes Dr. Smith sees that may put you at greater risk.
Wearing sunscreen is good, and I think people sometimes get misled by SPF. They look at SPF 100 and they think, oh, I'm good, I'll go out and wear this and I'm doing what I need to do. And what people don't realize is that a lot of times they're not blocking UVA, they're only blocking UVB. So you got to be sure you have a broad spectrum sunscreen. And also a lot of the really high SPFs are chemical sunscreens, and they actually degrade in the sunlight very quickly. And so they don't remain active for as long as people think they do. So you really do have to reapply. Of course, staying out of the sun during the peak hours is important, but what I do and what my family does is we actually use sun protective clothing and hats, and I have found that to be a huge benefit over just doing sunscreen. The other big thing that I really counsel people about a lot is not going to the tanning bed. I don't think people understand just how bad the tanning bed is. I think they think that it's kind of bad, but not as bad as smoking, but actually you're more likely to get skin cancer from going to the tanning bed than you are to get lung cancer from smoking. And so you should not go to the tanning bed ever for any reason. And the idea that you're going to use the tanning bed as a way to not burn on vacation and that's somehow a healthier behavior has been completely debunked. A tan is a sign of damaged skin. We don't use sunscreen to make it so that we can lay out longer. That's actually a dangerous behavior as well. You know, people who are really fair-skinned, it used to be that they would get a sunburn and they would realize they needed to go in and they would get out of the sun. And now, because they can prevent the burning, they stay out longer and expose themselves longer to those ultraviolet A rays that we think are important in not only skin cancer, but also in skin aging.
Dr. Smith also reminds us that skin protection is a year-round venture, not just in the summer months, especially if you participate in winter outdoor sports. More StantonMD is coming up, so stay with us.
Don't let cancer keep you from enjoying the little moments in life. Court Physical Therapy knows those moments are important, and cancer doesn't have to slow you down. Studies show that people who routinely exercised had a 40 to 50% less fatigue rate and significantly decreased their risk of reoccurrence. Court empowers you to take an active role in your recovery and get back to enjoying life. Whether you like summer cookouts, Little League baseball games, or a trip to the lake, Court will design a plan to ease tightness, aches, and pains and increase strength and flexibility. Court is there for you every step of the way. For more information, visit KORT.com. Court Physical Therapy.
Welcome back. Breast cancer is the most common form of cancer in women after skin cancer. This is one of the most important cancers for screening and early diagnosis. Dr. Kimberly Steigers is a board-certified interventional and breast imaging radiologist with Kentucky One Health.
1 in 8 women over their lifetime will develop breast cancer. And that kind of equilibrates to about 12% of women in the population. Breast cancer is the second most common cancer next to skin cancer affecting women. Of all women that die of cancer, 30% of those are due to breast cancer.
Every woman is at risk, but some have a greater risk and need early evaluation and screening.
The women that are increased risk and we need to alter their screening method just a little bit are a couple big categories. First off would be women that have a first-degree relative with breast cancer, meaning mother or sister, particularly if their mother or sister had breast cancer before menopause, typically before 50. Those women are at fairly substantial increased risk, and they may qualify for genetic counseling to maybe see if they have increased risk and would qualify for other screenings such as a breast MRI. The other category related to that are women that test positive for the BRCA genes, which is BRCA1 and BRCA2 genes. We call them the BRCA genes. These are genetic isolated genes that have mutations that have a very high incidence of a woman developing breast cancer and some other cancers as well, namely ovarian cancer. And those are patients that had radiation to their chest when they were very young as teenagers.
The key to breast cancer is early diagnosis and recognition.
We want to find it early, we want to find it when it's treatable, and we want to save every woman from all the bad things that can happen and try to help them.
Breast cancer screening is also something that women can do at home. A monthly self-breast exam can be life-saving when it comes to finding cancer or lesions that would require further evaluation on top of the traditional screening.
Those of us that see this every day, those of us in the breast imaging field, we do not want women to ignore what they feel in their breast. It's important to do a breast exam once a month. Anything that feels different to that woman, it may feel like a thickening, it may feel like a small little lump, nipple discharge, particularly nipple discharge that comes out on its own and is bloody, are worrisome findings.
The best approach to the early recognition of breast cancer is screening examinations. There's been a great deal of debate and questions over the last few years, but Dr. Steigers stresses that screening mammography is still the best method for finding breast cancers early.
We know that screening mammograms decrease the mortality or the people that die from breast cancer by 40%. That is tried and true over decades of studies and large studies involving hundreds of thousands of women. The best way to detect breast cancer early is through a mammogram. And the best way to prevent breast cancer deaths is by starting that at age 40.
The screening of breast cancer involves several methods of imaging, including traditional 2-view digital mammography, breast ultrasound, MRI, and the newest technology, 3D mammography known as tomosynthesis. When it comes to imaging and screening, Kentucky One has a program available to ensure that everyone has access to the highest level of care. The program is called Yes Ma'am.
The Yes Ma'am program is something we're very proud of. It has been in effect for about 3 years, and we have taken care of about 1,500 women through that program. It is 100% funded from donations, and we've received those through many sources, one through the pink license plates. A lot of women have insurance, but they're underinsured, or they have a large deductible, or they have insurance, but they can't get here to get a mammogram because they don't have transportation. So this program provides free mammograms for these women. It provides an ultrasound, a biopsy if something is found from that initial screening or if they have a problem. We work very closely with the Kentucky Cancer Link, and they are a great resource to us to help funnel the women into this program.
As part of this program, the Kentucky One Breast Center at St. Joseph East has dedicated its rooms to patients and families special to the program. At the center, there are several options to get your screening done.
We would love to be that first stop for women and or men that have a problem. For women, getting a screening mammogram is really very, very easy. As long as you have a doctor, we need for the patient to have a doctor, so we have a follow-up to send a report and have someone else following the patient. But you do not need an order to have a screening mammogram. So if a woman has no symptoms, she's 40 and above, and has no symptoms, can come for a screening once a year. Almost every insurance will pay for that. If you don't have insurance, we have this fabulous Yes Ma'am program that we can funnel patients through the Kentucky Cancer Link and get them here for a wonderful mammogram, including 3D.
If you are at high risk, age 40 or older, or have a concerning lesion, I strongly recommend you to take the steps to get the necessary screening to rule out or rule in cancer. The earlier it's caught, the better the chances for a full and complete recovery. That's all the time we have for this episode of StantonMD. If you missed an episode or want to watch a segment again, you can head to our website, StantonMD.com. I also invite you to join our community by liking the StantonMD Facebook page and following me on Twitter @EverydayMed. We welcome your comments and suggestions. Email us. The address is info@StantonMD.com. Until next time, I'm Dr. Ryan Stanton, and this is StantonMD.